So OCT is a must to identify these very subtle and very transparent membranes. Without OCT, it's very difficult, even with the contact lens viewing system, it's very difficult to visualize these membranes. So whenever you have a doubt on, thanks. Slides are not some here. So don't know. See you on the top. It's not moving. So when you have a case where you feel that the presenting vision is not corresponding to the amount of cataract or the level of cataract, then always make sure that in case you see a normal looking fundus with a dulling of foveal reflex, make sure that you get a OCT done. Apart from routine slit lamp examination, it's easily missed because it's all very transparent membranes and very subtle separation of the retina surface. And now people have, most of the cataract surgeons have included OCT as a pre-operative workup to avoid post-operative surprises and having the need to explain to the patient regarding what went bad or what was pre-existingly present, and then make them understand. So vitreous retraction is nothing but a partial separation of the vitreous. Normally the sequence of separation is from the perifoveal area, the vitreous separates first, then the arcades, then the fovea, then the periphery. So when you have an incomplete where it's attached to the perifoveal area, that's what we call this vitreous macular traction. This can be because of trauma, inflammation, vascular disorders, a lot of things can, and age-related causes, all this can present as a reason for this. Normally, how a PVD develops is that you have synthesis is happening in the vitreous body, formation of lacunae, which then move on to break into the posterior part, fuse into a large lacunae, and then break into the subhyaloid space, cleavaging the vitreous from the retina. This is what we call as posterior vitreous detachment. And when this is incomplete, there is a persistent adhesion at the fovea, perifoveal area. That's what we call it as vitreous macular traction. So when there is no tractal effect with only partial separation of vitreous still attached to the perifoveal area, we call it as vitreous macular adhesion. And this is mainly because partial separation of the vitreous is within the 3 mm of the fovea. So when you start seeing tractional effects either in the inner retina or which can go on to produce cystoid macular edema, like you can see here, or when you have a persistent traction full thickness macular hole, or like this partial thickness in the outer lamellar hole, or a full thickness macular hole with separation of the vitreous. These are all things can happen. Here you can see the earliest sign where you have a slightly indentation of the inner lacer retina. So all these, when you start seeing vitreous macular traction symptoms on the inner surface, or like in this case you can see the outer surface, there's some breakage here. It can be the inner or the outer surface of the retina. So when it starts happening, then we what is vitreous macular traction syndrome. So sometimes it's because very transparent and the additions are very small. Sometimes in 3D when you can make out it's even better seen than a routine 2-dimensional OCT. You can see here, you can see the 3-dimensional very spectacular view of the both the skytic vitreous and the riveted retina. So sometimes moving on to the 3D viewing system can sometimes give you a better perception of all the various additions in and around the fovea. So what to do when you have a persistent macula and the retinal problem? So if the cataract is cortical type, or when there's a posterior subcapsular cataract, usually the cataract is the main cause of vision loss, you can go ahead and operate. But especially in nuclear sclerosis, when your vision is not corresponding, always, as Raja was finding out, discuss with the retinal surgeon and then make your plan of action rather than avoiding disappointment later on, after both from the patient's side and your side also. So what are the options for treatment is observed. When it's a very mild traction with not much of vision loss, then you can go out with the cataract surgery and forget about the retina and follow it up later with your colleague. But when the indications include when there's a considerable vision drop not corresponding to the amount of cataract, especially distortion, especially if the patient is a very high active professional, sometimes distortion can be a really big issue. So in those cases, it's better to operate either first or combined. So the treatment options include, in India it's not available, in the Western countries you have the Jetria, with very poor success rate, less than 1/3 of patients went into separation of the vitreous from the retina. So not commonly preferred, but this is one of the medical options where the patient is not willing for surgery in the outside world, not in India. So other main, what we do here is surgical technique. You can see very stiff vitreous here, where it's still attached to the posterior pole, fovea that is. So here you have to be very careful about separating the vitreous, not to include traction and convert foveal cyst into a full thickness or a lamellar macular hole. So we try to do with low suction, try to make the central vitreous an island, and then go ahead with your peeling techniques. So you can see now we are trying to go around the fovea, to avoid converting a foveal cyst into a full thickness macular hole. So you can see now I made a small island. So at this point, we have options of either stopping here and leaving it intact because now we have released the traction, the foveal cyst will subside on its own. Or if you're not sure, you may have inadvertently created a macro hole, then you can go for a ILM peeling say next to that, so that when you peel the ILM, the separation of the vitreous from the perifocal surface is much more atraumatic, the lesser risk of causing iatrogenic holes. Here now a peeling is being done, and with that you can see the foveal tag is coming off now. The last part of release should be the fovea, peel all around and then come to the fovea, and the final point when release, the risk of converting this very thin walled foveal cyst into a full thickness hole is much more reduced. Here is one case where you have just left the small island intact, and you can see the foveal cyst is slowly subsiding. It will take a few months to attain near normal anatomy. This is a case of severe non-proliferative diabetic retinopathy with coexistent vitreomacular traction. Again, showing the same step where I'm trying to do the, now first you have made the island into a small island now. Now this is the completion of the vitreous island first with no suction and no cutting, high cuttings rather. So now we are going for ILM peeling now. You can see the ILM peeling using the asymmetric ILM forceps. The last part of separation will be the fovea. First you peel all 60 degrees around the fovea, and the final releasing point will be from the foveal surface. This way you can avoid the conversion of foveal cyst into iatrogenic macula. So sometimes you should be careful that all the three layers, that is the vitreous, the ILM and the epidermal membrane, can be fused into a single layer. And sometimes when you are a little bit very forceful in inducing a PVD, it can rupture all the three layers together, causing iatrogenic macular hole formation. So whenever you have a very densely adherent membrane, be sure that you do it in a very slow way. Don't try to induce the PVD in a very forceful, like a routine case where you do it. This is just showing pictures of preoperative and postoperative. This is some of the published protocols which are available online. So my conclusion is that if you have a very mild cataract, do the treatment of the VMT first. If you have a significant visually that is obstructive cataract, go with combined you can do both phaco with vitrectomy. And phaco only if cataract is dense enough, you do not able to assess the posterior segment. You do the cataract first, then assess the retina, and then go ahead with your BR70 if it is needed. Thank you.